Welcome to the award-winning Women in Healthcare Leadership podcast series brought to you by Medscape Education. Our mission is to educate, advocate, and inspire women in healthcare to lift as they rise. Each episode brings you voices of leaders who are breaking barriers and leading the way in advancing women's health. Join our global community of listeners as we hear from her. Ready to be part of the movement? Let's dive in.
Welcome to today's recording of our Hear From Her Women in Healthcare Leadership podcast series. My name is Yelena Sparopoulos, and I'm the Vice President of Education at Medscape. I have with me today two outstanding panelists. First, I want to introduce Dr. Mollie McDonnold, who is a maternal fetal medicine specialist at St. David's Women's Center in Texas, Austin. Welcome, Mollie.
Thank you. Happy to be here.
Very happy to have you. And along with you, I also have Zhenya Lindgardt, who is the president, CEO, and board director of Sera, the pregnancy company. Welcome, Zhenya.
Thank you so much, Yelena. Great to be here.
I am really excited to discuss a very special topic today. And I'm really looking forward to educating our audience about an extremely important issue that has the potential to affect every pregnant woman. The issue at hand that we're discussing today is spontaneous preterm birth. And I wanted to ask both of you, before we get into our topic, from a professional career perspective, how did you find yourself as a leader in this fascinating field? And Mollie, maybe we can start with you. What led you to a career in maternal fetal medicine?
I'm sure, as most people know, before you're a maternal fetal medicine specialist, you train as an OB/GYN. I found during that training that I loved the OB portion. But what I really loved was that it was you were really taking care of two patients at the same time. And you have to think of the well-being of both. Um, there are just very interesting both medical complications of pregnancy as well as pregnancy exclusive complications of pregnancy. It's just very interesting in how the physiology of pregnancy changes, just chronic disease as well. And so all those things came together, and I found it a very fascinating subject, and really enjoyed taking care of those patients.
Mm-hmm. Absolutely. And Zhenya, I can't even begin to explain to our audience what a fascinating career you've had, right? You've had a leadership position at Uber, and now you lead a pregnancy company. Can you tell us a little bit more how you got to your current position?
It's definitely a winding story, but I could not refuse when Dara Khosrowshahi, the CEO of Uber, who picked up from the founder Travis Kalanick, invited me to join Uber before the IPO. I wanted to see what it's like to help lead a tech unicorn. And as a mom of three girls, I led the corporate incubator, and I was thinking, where can I deploy my energies and my learnings over a career in business and then growing young businesses. And when Sera Prognostics reached out to me, my predecessor, and invited me to join the board, I was overjoyed because having been pregnant, we have so many opportunities to improve lives of, as Dr. McDonald said, of babies, of moms, of the experience. I think the cause inspired me, and I first joined the board, and then the board asked me to step in when my predecessor retired. So I'm really excited about today's conversation, and hopefully contributing one small part in all of your vacations in helping save lives and improve health of moms and babies.
Yeah, and let's get into it, if you don't mind, because I was really fascinated when I read about this. But based on the recent statistics, and I'm talking 2024, the U.S. preterm birth rate is over 10%, 10.4%. And really, it's remained essentially unchanged for decades. So, Zhenya, we know this contributes to significant neonatal morbidity and mortality. Can you comment on this from your perspective and from where you stand?
Definitely. Well, it's second biggest cause of death for neonates, prematurity. And indeed, 10.4% is 1 out of 10 babies are born with significant biological and societal disadvantage, I would say. Especially the earliest born have lifelong implications on their health and now proven on educational earning potential and a lifetime. Um, to varying degrees, of course. But that 10.4% rate is much higher than many other nations. And it actually increased over the last decade or two, Yelena. And it's so common, 1 out of 10. We're talking about genetic diseases, rare diseases, and a lot of innovation in this space. But this condition is, or an outcome, I would say, because it's, as we'll talk about, I'm sure today, has many causes, prematurity, preterm birth, um, is so common that 1 out of 10 babies face it, and families face it because it carries a significant toll. Imagine a new mom, sometimes with other kids at home, needing to spend time in the NICU. It's very traumatic for families. Constant medical appointments. The first years of life are frequently spent running back and forth to the hospital, to the emergency room because of respiratory complications. Any cold creates a lot of concerns. Huge toll on healthcare systems, of course, and all of the physicians caring for moms and babies. The cost of the system many years ago was 25 billion per year. It's one of the leading cost items for Medicaid inpatient costs. 27% are childbirth related expenses, where the earliest born babies stay in the NICU for 3 or 4 months. So, preterm birth, preterm born kids have higher rates of disability, learning difficulties, and many other complications. Same for moms. 8 times higher postpartum depression rates for moms who went through this. Sometimes PTSD from traumatic experiences with their baby in the NICU. So a lot of implications of this outcome that now can be prevented.
Yeah, and I definitely want to get back to this issue of the impact on healthcare resources, not just sort of in that immediate period, but lifelong, right? But before we get there, I just wanted to turn over to Dr. McDonald and ask her from her perspective as a healthcare professional. Is this, sort of what you see in your practice? And do you think that healthcare professionals are aware of this?
One of the, main things that we are involved in, and, I certainly, obstetricians who are working day to day are aware of the risk of preterm birth. I don't know that I think it's hard to sometimes appreciate, from the standpoint of what happens after, though, in terms of all the care that has to happen in the NICU, all the care that happens after babies go home, and all the experience that moms have, and how much they uh, risk they, especially as you pointed on the risk of things like postpartum depression. And those are kind of other aspects of preterm birth that we don't always think about. Um, I think I think really the population that's not aware are just families who are becoming pregnant. So many times I see patients and they everything's going fine, and then all of a sudden they're encountering this, and it's kind of like we didn't expect this. I didn't anticipate that this could happen to me, and it that amazes me because it is such a common issue. Um, to think that something that happens to 10% of pregnancies couldn't happen to me is something that I'm always uh, amazed by. But no, it's a very prevalent issue, and it's a difficult, complex problem in society.
Yeah, and I want to go back to something that Jenya said, and that's really the economic burden of families and the healthcare system at large, which really extends well beyond that first hospital stay. So, Jenya, can you talk a little bit more about the lifelong implications of a preterm birth? that, happens with lives, children, families, and, are also related to all the different healthcare resources.
Yeah, no, as adults, people born preterm have higher rates of cardiometabolic diseases and have some evidence of earlier onset of chronic conditions, which may contribute to premature aging and reduced productivity. According to research, the lifelong healthcare costs of adults who were born premature range from tens of times of the costs of a healthy full term baby to up to 300 times um, over a lifetime, which is an enormous strain. And of course, if you can imagine societal health, babies who were born premature grow up to be less healthy adults. They may not have as healthy pregnancies. So the cycle perpetuates over decades. And that's why I think, partly, of course, the preterm birth rate is inching upwards. It's actually double-digit growth, even though these are small percentages, but it went from 9.6% a decade ago to 10.4. That's not small. That's big. We're moving in the wrong direction, unfortunately. And you've all known the maternal mortality rates in this country and utilization of the NICU. Babies have a much higher chance of ending up in the NICU today than even 5 years ago.
Absolutely. So let's talk a little bit more about what we can actually do. So I am going to I'm going to address this question to both of you, right? So, um, what can we do today based on the latest studies to assess risk and to predict which women are at risk? I know that you were both involved in a large study that evaluated this. So maybe Zhenya, we start with you. Can you mention what was studies and what were the findings in terms of that risk assessment to predict which women are at risk for preterm birth?
Thank you. We partnered with 19 study sites across the entire country and worked with over 5,000 patients to test a few outcomes. Number one is health of the newborn via a composite index, neonatal mortality and morbidity, and saw 20% reduction in severe morbidity outcomes. And second outcome we tested was gestational age at birth and saw 52% reduction in babies born before 35 weeks or 32 weeks and 30 plus percent born before 35 weeks. And the most exciting outcome that we've seen from that study was that 1 out of 5 babies avoided going into the NICU. And we did see the reduction in the NICU stays for those who did make it to the NICU. So terrific outcome. But I'll turn it over to you, Dr. McDonald. You were a critical part of the study, one of the study site coordinators.
Yeah, such an important study to be a part of, and it was so exciting. I think what a key piece to kind of understand that really prior to this study, we have very few tools to help predict who's at risk for preterm birth. Um, we know that women who've had a prior preterm birth have a very significant risk, but those women don't make up the majority of preterm births. The majority of preterm births occur in women who have had no prior preterm birth. And another piece that we had to look at was the cervical length. So looking at the cervical length in the mid trimester, and if you note a short cervix, that is considered a risk factor for preterm birth. But that is a very resource intensive procedure to perform, and it's not something that everybody has access to. So I think the exciting thing about this study was number one, it's looking at another tool to help predict preterm birth, which is shown to actually be very sensitive, which just involves a blood draw in the early part of pregnancy. And the kind of cool thing about that is it's looking from biomarkers from the placenta, because we've long thought that the placenta is the key to understanding the pregnancy. And then it went on to, look to see, well, if we can identify those women who are at risk, is there anything we can do to help prevent?
If I can jump in to add to what Dr. McDonald is saying, the recent few decades of research show many, many risk factors for preterm birth. from nutritional deficiencies, from domestic violence to particular socioeconomic factors, as well as comorbidities, chronic conditions, diabetes, hypertension, etc. If they're added up when the physician assesses an pregnant mom who shows up in her office, over half have some risk factor for prematurity. And certainly, according to guidelines and just constraints of the practice, the physicians cannot treat everyone specially who have some risk factor. And the healthcare system cannot have half of the pregnancies be designated higher risk. So that's why it's so important to utilize innovative tools that can predict using that personalized test to assess this pregnancy, because from pregnancy to pregnancy, the risk is different, the health of the mom is different, the context is different. That's what I think is the key advantage, is helping physicians have more tools at their disposal to understand which pregnancy needs extra care, which pregnant mom needs that extra visit to make sure that she shows up for it. And then consequently, which moms, because the test has very high negative predictive value in the high 90s percentages, if the test comes back with a result that is negative for higher risk, it's very likely that it's going to be a calm, steady pregnancy, giving the physician the opportunity to also perhaps calm down the anxious patient, saying this is looking good.
Absolutely. And so I want to just follow up on that, Jenya. Maybe I can go back to you, right? So great strides in terms of identifying who is at risk and who is not at risk. But then what about the prevention piece? What can we actually do then once we identify these women to prevent preterm births or reduce that rate?
This is a great question, and this is in the study design why we worked with the Society for Maternal Fetal Medicine to help design a protocol of what can be the intervention bundle to then apply to women identified with the biomarker-based test to prevent preterm birth or to ameliorate the health effects on the baby and the mom. And the recommendation was to test baby aspirin, low dose aspirin daily, which I know all of you are using in your practice already. Vaginal progesterone applied daily, and weekly nurse call using a specific protocol that we already published, which is very straightforward, just checking symptoms and helping educate the mom on what to watch out for. So this protocol has very well documented, safe, and efficacious interventions, but applied to a subset of women, it had a spectacular set of outcomes in the study. And of course, it's up to the physician how to treat the moms, but prime study outcomes show that this preventive bundle of just 3 interventions could have terrific outcomes for the pregnancy.
Yes, when I read the study, I was amazed because, you covered the outcomes, including that 20% reduced risk of complications with that proper intervention. So that's really terrific to see. I want to go back to Molly for a second because you're, in clinical practice. So how do we actually then implement these results in practice, right? We know that, there's a very common misconception and perception that taking any kind of medication during pregnancy is unsafe. So how do you use this information then to talk to, the women who are pregnant, who are coming to see you, to talk to other HCPs to really explain the benefits of this and really the minimal risk associated with the, intervention?
Big conversation that I have with patients a lot is that it's not medication versus not taking medication. It's the medication versus an untreated disease, or in this case, an untreated risk factor. We know from excellent research, excellent experience, that the vast majority of medications that we use in pregnancy are very safe for the fetus on a number of levels. Number one, the placenta itself is designed to allow certain things in and certain things out. But but also we know that exposure to some of these things is completely okay for the baby. We have documented evidence to say no harm. In fact, probably harm not doing these things because the outcomes are so much better when you do them. And so we talk a lot about this. These particular interventions, the aspirin, low dose aspirin, 81 milligrams a day, as well as vaginal progesterone, have been widely used for other indications in pregnancy as well. And so it's with excellent outcomes. We've been using low dose aspirin for the prevention of preeclampsia in high risk women. This has become a really almost universal recommendation from many societies that women should be doing this, and that's really then spread out to many other indications as well. And then vaginal progesterone has a long history of use in terms of prevention of preterm birth in women who have noted cervical shortening. And so it's just taking things that we were already doing, that we already have excellent safety and efficacy data on, and applying them to a slightly different risk factor.
Yeah, and I want to go back to you to just dig a little bit deeper about these barriers to, using appropriate, prevention. So what else can we do to sort of reduce that anxiety for the patient? And who is responsible? Is it, the maternal fetal medicine specialist? Is it the OB-GYN? Is it the nurse in the office? I think that multi-specialty care component definitely comes into play here too.
Well, yes, I think on every level we have responsibility. You know, patients are seeing things from not just us in the office, but all over. We have the internet and we have social media, and the message that they're getting there is not always the right message. And it's not always what we know to be true and what we know to be factually based. And so, really, it comes to us as professionals, both as the maternal fetal medicine specialist, as the obstetrician, as the nurse in the office, as a midwife who's seeing the patient. It comes to all of us to really reassure these patients that our goal more than anything is for them to have a healthy baby. And so I'm never going to recommend something that I think would um, not lead to that goal. And so whenever we're recommending a medication, I'm doing that with the background that I believe this is safe for your baby and for you.
I think that, this is a really important issue. And the more educated and aware everybody is, including healthcare professionals, it's really going to make a tremendous impact. So Zhenya, from your perspective, what other resources currently exist to help HCPs address this issue? And how can we, all of us as a healthcare community, what can we do to collectively to help to address this issue?
Great question. I think the innovation in itself, arming the physician with a report that allows the physician to convince the mom to, as Dr. McDonald said, that the protocol is safe. And a prime study that we've talked about is the third in a row with the same protocol we've tested that successfully again showed in a prospective randomized trial how effective this bundle of interventions is will help in itself, as Dr. McDonough said, to engage with the moms and really stratify who needs this protocol and who doesn't. Um, uh, to me, the three other important opportunities to support the physician is patient education. As we've talked about, the awareness is incredibly low among the general population about amongst women who are pregnant, especially for the first time, about the very real risk of preterm birth, that 1 out of 10 babies will be born premature. So we've developed an incredible amount of patient education materials for the waiting room. Happy to support the physicians in educating the patients. Um, Second is care management. Weekly nurse call. We all know obstetric nurse capacity is incredibly short across the country. And there are tools that we can provide to support care management delivery. There are many states that provide resources for care management delivery. Many payers. Um, I think that's a clear opportunity to support the physician offices, not to have care management delivery be the barrier, but have a third party help deliver that and support the office. So from that perspective, even technology tools we can provide to the office where the physician will get weekly report on how the patient is feeling. It's through the EMR at a convenient time for the mom as well. So that the patient can be monitored. So these are just some of the support mechanisms that it's important for the whole community to provide to physician to help integrate this new test.
Yeah, lots of great advancements, I think, clinically, but also from that, infrastructure perspective. So I know we talked about a lot of things and we're almost at the end of our podcast, but I want to finish up by asking you both a very big question. And maybe, Molly, we can start with you. What do you think the future holds? Where do you see advancements happening? And will we see, brighter future with fewer preterm births?
Well, I think the future is very exciting. I think that we're understanding more and more these early biomarkers and pregnancy, not only for predicting preterm birth, but also predicting other complications that lead us to have to deliver babies early, like preeclampsia. I think that, um, but the key here is that it as 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 the population grows and expands, but as we also have, uh, we're facing to a degree a provider shortfall. We don't have quite enough providers to provide, and so we really need these tools to help delineate who's at risk and who's not in order to really make sure that we're putting the right resources for the right patient. So being able to identify this patient is at significant risk of preterm birth. And so therefore I can, funnel my cervical length monitoring tools and I can funnel my nurse support system to this patient, while at the same time identifying that this other patient is in fact not at risk, but she has other things that I need to be focusing on. I can really improve outcomes for both of those patients, and that's so important as an obstetrician and a maternal fetal medicine provider. So really being able to identify with high sensitivity who's at risk and who's not at risk, and how we can really make sure that we're doing the right thing for each individualized patient is very exciting.
Totally agree. And Zhenya, what about you? Same question to you.
Well, to build on what Dr. McDonnold is saying, it's so exciting to see the way the future is going, that the clinical community is moving to tailored prenatal outcomes or prenatal care protocols stratified by the need of each individual pregnancy. And it's true that in pregnancy care, one size does not fit all. And ACOG last April issued a bulletin specifically saying, we really need to move away from this standard prenatal care delivered to all. So seeing this tailoring hopefully will free up some resources from pregnancies that are going well, that don't show any signs of risk, to those who really need it, to expand access to care, to reduce disparities, to address a lot of moms with higher risk as a population, for example, Medicaid, or the racial disparities we see in outcomes. I'm really excited to see this happening in real life in our lifetime, and supporting this journey.
And I think we definitely need to have a follow-up podcast, and we're going to discuss the, preterm birth rates, and I'm hoping it's way less than 10.4%. So with having said that, I want to sincerely thank both of you for joining us today. It was a great discussion. And for everybody listening, please tune in to our next episode. Thank you, everybody.
To our listeners around the world, thanks for joining us today. Tune in as we continue our journey to amplify the voices of women leaders in healthcare. Hear From Her is brought to you by Medscape Education. Please subscribe to Hear From Her on your preferred podcast channel and follow us on LinkedIn. Until next time, remember to lift as you rise.